Greetings. Let's head on into the atrial dysrhythmias. The last video took care of the sinus family and dysrhythmias associated with the SA node, and this presentation is on atrial dysrhythmias. Today we'll talk about the 7 dysrhythmias in the atria. The wandering pacemaker, multifocal atrial tachycardia, or MAT, atrial tachycardia, premature atrial contractions, PSVT, Atrial Fib, and A-Flutter. All right, remember your chart that we built in the sinus family. Develop that same chart. Get your 5-step rhythm recognition and place those 5 steps on the left side of your axis and your names of your atrial rhythms across the top. So with the wandering pacemaker, the rate is usually normal. The rhythm slightly irregular because of the different locations that your P waves start. Remember, the P waves are that atrial depolarization. So this wandering pacemaker wanders from the SA node to somewhere in the atrium, back into the SA node, and back out somewhere in the atrium. So each P wave looks different. Remember, the things we look for when we analyze our P waves are they are present. They are upright or inverted, one for each QRS. They are regular, and they all look alike. Well, with the wandering pacemaker, your P waves change with every beat. Your PR interval is normal, 0.12 to 0.20, and that QRS complex is also normal at less than 0.12 or 3 little boxes. Go ahead and copy the URL down below and paste it into a browser and watch some of these people wander after having a little too much to drink out on the town. That's what makes me think about the wandering pacemaker. Enjoy. All right, like we said in the last slide, this pacemaker, this signal starts in the SA node and then wanders out into the atrium somewhere, wanders back into the SA node, and wanders back out into the atrium someplace. So it's a variant of a sinus dysrhythmia. It can happen in the very young or the very old, and it's indicative of that ischemic heart disease. And when your atriums start to dilate, swell up due to too much fluid in there. And sometimes your P waves may completely disappear. Just as long as your ventricles are pumping blood out, there's no really detrimental effects here, but it is a sign that something more lethal is coming, like A-Fib, and that's a bad thing. It's sometimes an indication of digitalis toxicity. Now remember, we talked about the digitalis plant in the sinus rhythm presentation. Most of the time with these atrial rhythms, they are fast. So a little faster than normal in that tachy rate, And we need to slow it down because if our heart gets too fast, over that 140, 150 beats a minute, it goes too quickly to pump out blood effectively. And if you can't have cardiac output, you cannot have blood pressure. So we're going to think about slowing it down with adenosine, verapamil, or cardiazem. And on the trucks nowadays, we have some labetalol. All right, let's talk about MAT, multifocal atrial tachycardia. It's a tachycardia, so that heart rate is over 100. The rhythm is irregular because there are 3 areas. Look at the picture here. There are 3 areas, at least 3, in the atria that are sending these signals to the AV node to make that heart beat really fast. The P waves, they are organized non-sinus. They're non-sinus because they all look different. And with multifocal atrial tachycardia, there's at least 3 forms. There's that form, little loop, this is a little more spike. Hey, look at this crazy thing right there. They all look a little different. And that differences comes from the different locations in the atrium where these signals come from. The PR interval depends. The PR interval depends on how high up in that SA node. Is it up here close to the SA node and the signal comes down normal, or is that ectopic foci somewhere down here close to the AV junction or AV node and the PR interval is shorter? So that PR interval is a little variance with multifocal atrial tachycardia. However, the QRS complex can vary also. It can be a little wide or it can be narrow. Like I said, the difference between wide and narrow is less than 3 little boxes on your EKG strip or over 3 little boxes on that EKG strip. Just remember, Matt is sick. Remember, Matt is sick. Acutely ill patients, serious underlying illnesses here. Big thing, 3 different types of P waves, tachycardic rate. Matt is sick. So remember that. Since Matt is sick, we need to figure out that underlying illness. Look at these crazy P's here. And we're at a fast rate. Matt is sick. Figure out that underlying illness. Look for those 5 serious signs and symptoms. Do they have altered mental status? Do they have signs of acute heart failure, which can be JVD, pedal edema? Do they have chest pain, hypotension, and any signs and symptoms of shock? And treat those as necessary. Let's talk about PACs, or premature atrial contractions. They just pop up every once in a while. They're not technically a rhythm on their own. So the rate depends on the underlying rhythm. It could be fast, it could be slow. It could be somewhere in the normal range. So the rhythm is usually regular, except for this little pop-up PAC. That pacemaker site is somewhere in the atrium. Remember the principles of the cardiac conduction system. Everybody wants to start the wave. So hey, this little guy says, I want to start the wave. Sends the signal racing down to the AV junction. Bundle branches in the Purkinje fiber, and they can start the wave. So remember, every cardiac cell has the ability to start the wave. Automaticity, excitability, conductivity, and contractility, the 4 principles of the cardiac conduction system. So P waves occur earlier than expected with this PAC. So PR interval varies depending on where that ectopic foci is, how close it is to the SA node. If it's close to the SA node, then that PR interval is probably normal. If it's closer to the AV node in the intra-atrial pathway, that PR interval will be a little shorter. And the QRS complex is usually normal, less than 3 little boxes or 0.12. PACs are just one single electrical impulse outside of that SA node. And then there's a non-compensatory pause. There's a pause that resets that SA node, so it fires, sort of shuts down that little ectopic foci. So what causes this? Hey, caffeine. So let's go chug some energy drinks, maybe tobacco, alcohol, some pathomimetic drugs, and all the others. Or it just may happen, who knows why, idiopathic. Since this is just one isolated ectopic foci that happens every once in a while, there's no real clinical significance. The heart still fills up and the ventricles still pop out. So treat any underlying causes. If they're symptomatic, discover that underlying cause, get that IV, put them on O2 if they're hypoxic, less than 94%, and check out that 12 lead. See if there are any issues. Nothing too crazy with the PAC. Next is PSVT, or paroxysmal supraventricular tachycardia. It's paroxysmal because you see this rhythm change from slow to fast. So if you see it, it's PSVT. The rates can be really fast, 150 to 250 beats a minute. And remember, at that speed, our heart does not have enough time to fill up. The rhythm is usually regular. The pacemaker site is outside that SA node because we are definitely faster than the intrinsic rate of the SA node, which that intrinsic rate of the SA node is 60 to 100, and we're at 150 to 250. Often this rhythm is so fast that the P waves get buried in the T waves. If you can slow the strip down, then you'll see the PR interval is usually normal, but at this super fast rate, you can't see them. And the QRS complex is normal, less than 3 little boxes, or 0.12. Go ahead and copy this URL from the bottom of the screen or check out the link. This is SVT converted with adenosine. And we'll talk about that more in the next few slides. It's a rapid atrial depolarization that overrides that SA node. It's paroxysmal, so it stops and starts. You see it. It hasn't grown up to SVT. It's just paroxysmal. Stress, overexertion, caffeine, smoking. Clinical significance, it can be tolerated for a little while, but if the patient's ill, they won't tolerate this fast heart rate very long. Treatments for PSVT: vagal maneuvers, pharmacological therapy, adenosine or calcium channel blockers and beta blockers, electrical therapy, synchronized cardioversion. We've done this in the lab already, so consider it if that heart rate's over 150 and they are unstable. If they are fast and unstable, synchronized cardioversion. If it's PSVT and hasn't grown up to SVT yet, we can start at 50. If it's just SVT and you do not see it change, you'll start at 100 joules on your synchronized cardioversion. We'll talk more about the other therapies in a couple slides. All right, PSVT has grown up into SVT. It's no longer changing. It is just super fast, 150 to 250. The rhythm is regular. Pacemaker site is outside the SA node in the atrial someplace. P waves are difficult to see because they are buried in the T's. The P's are buried in the T's in this crazy fast rhythm. PR interval, if you slow this printed out, copied down, you can see them and they're normal, 0.12 to 0.20, and the QRS complex is less than 3 little boxes, or 0.12. Causes: caffeine, nicotine, alcohol, some cocaine. So the heart is beating too fast. The heart is beating too fast to fill up correctly. How are we finally going to treat this? I mentioned it a couple slides ago, but we're going to use the American Heart Association's tachycardic algorithm. Welcome to the American Heart Association's tachycardic algorithm. These heart rates are normally over 150 beats a minute, and if that occurs, the heart is going too fast to fill up. You're going to support your ABCs. Give them oxygen as needed. For O2 sats above 94%, start an IV, and of course get at least a 4 lead, but this is a cardiac patient, so we need a 12 lead. Then look for your serious signs and symptoms: altered mental status, signs of acute heart failure, or JVD, chest pain, hypotension, signs, symptom of shock. If they are fast and they are unstable, that means they have one of these serious signs and symptoms, synchronized cardioversion. You can see this pathway right there. It goes from serious sign symptom, wham, to synchronized cardioversion. If they don't have any serious signs symptoms, we're going to see if it's wide or if it's narrow. If it's narrow, which is what we're working on right now, if it's narrow, vagal maneuvers, adenosine, beta blockers or calcium channel blockers, and well, if that doesn't fix them, they definitely need a cardiologist. So we're going fast, stable, and narrow with our algorithm today. Fast, stable, and narrow. Remember, if they are fast and unstable, they could be fast and wide or fast and narrow. But if they're fast and unstable, synchronized cardioversion. So set your energy level. We're going to hit that sync button and we're going to set our energy. With SVT or A-Flutter, we're going to set it at 100 joules. With PSVT, we can go to 50, but SVT and A-Flutter, 100. V-tach is a fast but wide rhythm. We go to 100. And A-Fib, we've got a choice, 120 to 200. Most people hit that 150 range. Here's the steps. But just remember, we hit the sync button. We set our energy. We charge our monitor. We clear our patient and we push and hold the shock button. We push and hold so that computer in the monitor will synchronize that electrical discharge on that R wave. Sync, set, charge, clear, push and hold are your steps for synchronized cardioversion. The first step in our fast, stable, narrow algorithm is vagal maneuvers. We're going to ask them to Valsalva. They pinch their nose and they blow out, like when you're going on an airplane ride or over a tall mountain. So you Valsalva. With little kids, we can have them blow through a coffee straw, and sometimes that helps pop their ears, equalize that pressure from inner ear or middle ear to outside through that eustachian tube. Or you can have them bear down like they're going to have a bowel movement. Bear down, squeeze, that stimulates the vagus nerve also. Vagal maneuvers, vagus nerve, 10th cranial nerve. Or the carotid massage. We're going to push hard enough to dent a tennis ball. You got your pointer finger, you're going to point it nice and straight, and you're going to splint that pointer finger with your middle finger on top, and we'll show you this in lab. And you're going to push right here, the corner of the jaw, because at the corner of the jaw, if you look in the upper left picture, the corner of the jaw in the upper left picture is where your carotid sinuses receptors are. Those receptors in that area is the sheath that holds everything together, the sheath of the vagus nerve, the sheath of those sinus bodies. But before we start pushing hard enough to dent a tennis ball in that region, we're going to listen, just like the middle picture right here. We're going to listen at the corner of that jaw for bruits. And bruits is just turbulent blood flow through a partially occluded artery. And you see the wonderful plaque. What the heck causes that plaque? And what does a bruit sound like? It sounds like cheeseburgers, 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 cheeseburgers. Or a whoosh, whoosh, whoosh sound with each beat of the heart. So auscultate for bruits first. On each side, turn their head left or right to expose that area. Then take your index finger, splinted by your middle finger, and push hard right at the corner of that jaw and massage in a circular motion for 10 to 15 seconds. We'll practice this in lab. All right, let's talk about a couple drugs for PSVT and SVT. Adenosine is the primary one, and that works by slowing the conduction impulse at the AV node. It basically halts it. The patient will go into a systole, if you remember that video, for a few seconds in hopes that the SA node will take over and continue beating at a normal rate. So that's adenosine. 6 milligrams rapid IV push followed by a 20 cc flush is your adenosine sentence. I'll say it again. 6 milligrams rapid IV push followed by a 20 cc flush. If that doesn't work, in 1 to 2 minutes, we're going to give 12 milligrams rapid IV push followed by a 20 cc flush. And we'll practice that rapid IV push followed by a 20 cc flush in lab. If adenosine doesn't work, we can consider verapamil, a calcium channel blocker, or cardiazem. So it's a calcium channel blocker, and remember, in our action potential, calcium goes inside the cell with the sodium to help with depolarization and heart contraction. So if calcium is blocked, it slows down that depolarization. Negative dromotropic, negative electrical activity properties. Verapamil, negative electrical properties. Dromotropic. Remember those terms. If our adenosine doesn't work, we can use a beta blocker. Remember, the beta blockers are olol drugs like labetalol. So beta blockers are olol drugs, and they block betas. Remember your beta 1s and beta 2s, your one heart and your two lungs, and those functions are the code word cardio, contractility or squeeze of the heart, inotropic, squeeze, I know squeeze my heart, yeah, I know squeeze my heart. Automaticity is the A, and that's electrical conduction or dromotropic properties. R is rate or chronotropic properties, So C, inotropic, A, automaticity or dromotropic, and R, rate or chronotropic properties for our betas. D is our beta 2, two lungs, and that's bronchodilation, so we can suck more oxygen in our lungs because our heart is working harder. When I work harder, I get irritable and I have an increased oxygen demand. So remember your betas with the code word cardio. And beta blockers blocks that squeeze of the heart, blocks that electrical signal in the heart, and blocks that rate. So that means you're going to have a lower blood pressure, a lower electrical conduction, and a lower heart rate with beta blockers. If adenosine, calcium channel blockers, or beta blockers do not work, then we need to look for our H's and T's or other underlying causes. You can remember those underlying causes by the H's and T's. Hypoxia. You give them a little oxygen if their O2 status is less than 94%. Hydrogen ions. We can monitor their hydrogen ion output with our end-tidal CO2. So get our end-tidal CO2, our capnography, either inline capnography for a nasal cannula, or if our patients are intubated, you slap that cap on that ET tube and monitor the end-tidal CO2. Normal should be 35 to 45. So are they hypothermic? Give them a blanket, warm them up. The heating system in the back of the ambulance is not for you, it's for your patients. Are they hypovolemic? Little fluid boluses to maintain those blood pressures. And are they hypo or hyperkalemic? And that's potassium. And we can look at that potassium levels in those T waves, remember. That's our H's: hypoxia, hydrogen ion, hypothermia, hypovolemia, and hyperkalemia. Our T's are cardiac tamponade, coronary thrombosis, pulmonary thrombosis, tension pneumothorax, and toxins. Picture those hand and arm signals, students, and check out the video of H's and T's, PC and TC, H's and T's on YouTube. Another way to look at reversible causes in those H's and T's is determining these three things. Not enough in your heart and lungs. Are your heart and lungs being squeezed? Or are your heart and lungs killed in action? If that's not the problem, then you have to use your head. Let's go through these. Not enough in your heart means your patient's hypovolemic. If your heart is being squeezed, it's from that cardiac tamponade. And then if your heart is killed in action, it's from that coronary thrombosis or that myocardial infarction. So what do you think not enough in your lungs are? Yes, that's right. It's hypoxia. How about if your lungs are being squeezed? Yes, that's it. Tension pneumothorax. And if your lungs are killed in action, it is. Yep, you've got it. A pulmonary thrombosis or pulmonary embolism. Well, what else could be a reversible cause? Let's use our head. It could be hypothermia. It could be an electrolyte issue, primarily kalemia or potassium. It could be acidosis, respiratory acidosis or metabolic acidosis, and those hydrogen ions. Slap that cap and look at that end tidal CO2. And D, is it drugs? Use those toxins. How are we treating these H's and T's? With needles. We're stabbing them in the chest or stabbing them in the heart. Those needle thoracentesis or that pericardial centesis. You're reversing some drugs, or I should say you're reversing some electrolytes and hydrogen ions with some sodium bicarb. And, well, you got to ask yourself, is your patient on drugs? And try a little Narcan. That's how you can reverse some H's and T's. All right, if you didn't follow the link a couple of slides ago, go ahead and copy and paste this URL into a browser window and watch me on YouTube with the PCTC, AHA, H's and T's, and you'll learn the hand and arm signals for the H's and T's and reversible causes. Hope you enjoy it. Watch the video, then come on back to the presentation. All right, our next atrial rhythm is atrial flutter, the rate. Holy cow, are you crazy? The atrial rate is 250 to 350 beats a minute. The atrial rate, you'll see these shark tooth presentations here. That's the atrium beating 3 times for each ventricular beat, which you get a crazy fast rate from that. The rhythm, the R to R interval, is usually regular. Your R to R interval, which are your ventricles, are usually regular. The pacemaker site is outside the SA node in the atrium someplace, and it's making that signal go round and round and round, just like this picture. The P waves are actually called F waves. They're flutter waves. They have that sawtooth or picket fence presentation. The PR interval for the F wave that conducts the QRS complex is usually normal at 0.12 to 0.20, and the QRS complex is normal, less than 3 little boxes or 0.12. These atrial waves are just bombarding that AV node, and the AV node can't conduct all of the signals coming through. So the impulses may be conducted at a fixed or variable rate. Sometimes it's a 2 flutter wave to a 1 QRS, or a 3 flutter wave like in the last slide, or a 4 flutter wave to 1 QRS complex. It's normally associated with congestive heart failure. Congestive heart failure. Your heart's not squeezing enough fluid out, so it's starting to back up and stretch, is where you'll see some A flutter. All right, it's normally tolerated well as long as your ventricles are pushing out blood at a regular rate. Just as long as your ventricles are squeezing blood out. So there's only problems if the ventricles start going a little fast, and well, if your ventricles squeeze out too fast, they can't fill up enough. And if we can't fill up or preload, we can't output. And if we can't output, we can't have a blood pressure. So remember those combinations. You may also see a flutter with A-Fib, and that's an A-Fib flutter. And that's kind of fun to say, so go ahead and try it. The A-Fib flutter, A-Fib flutter. Check it out. Treatments for A flutter. Remember, if they are fast and unstable, they get synchronized cardioversion. So with A flutter, you're starting at that 100 joules. Remember the steps for synchronized cardioversion. You're going to sync, which means turn it on. You're going to set your energy for 100 joules. You're going to charge your monitor. You're going to clear the patient. You're going to push and hold that shock button. So if they are stable, we're going to think about Cardiazem or Verapamil, things like that. So your calcium channel blockers and beta blockers, because it blocks those calcium channels, which slows that depolarization. It blocks those beta properties, those rates, those squeeze, those dromotropic electrical impulses. That's why we use these calcium channel and beta blockers. If we use them at the same time, well, we're going to be blocking a lot of stuff, and well, that ends up to be a dead patient. So pick one and stick with it. All right, a whole lot of shaking's going on here, folks, in your atria, or A-fibrillation. A-fibrillation, your atriums are just quivering. The atrial rate can be 350 to 750 beats a minute. That's crazy. Your ventricular rate just depends on how many impulses get through that AV node. The rhythm is irregularly irregular. There's no rhyme or reason to all that shaking going on in your atria. So this is the only rhythm that's irregularly irregular. So the pacemaker site is in your atrium someplace outside that SA node. You cannot see any P waves. There are no P waves, just a whole bunch of little bumps on that isoelectric line from that fibrillation. Your PR interval, there is none, because you don't have a P, so you can't have a PR interval. QRS complex for the signals that get through that AV node, the QRS complex is normal. 0.12 to what am I talking about? Crazy man? No, that's the PR interval. QRS complex is less than 3 little boxes, or 0.12. Whole lot of shaking going on. Irregular is A-Fib. Remember that this fibrillation is random and highly variable. There's some underlying heart disease in there, clinical significant. The atriums fail to give us that kick, and that atrial kick, remember, helps fill those ventricles. So without that kick, we reduce our cardiac output by 20 to 25%, which is pretty crazy. So depending on the ventricular rate, you can have a high or low one, a Brady or a tachy, and that can compromise cardiac output. All right, treatments for A-Fib. If they are fast and they are unstable, fast over 150 beats a minute, and unstable synchronized cardioversion. Go ahead and copy and paste this URL or follow that link and watch a person getting synchronized cardioversion in an ER. So, fast and unstable. With A-Fib, you're going to start out between 120 and 200. Most people go 150. Remember the steps of your synchronized cardioversion. You're going to turn on the sync button. You're going to set your energy. You're going to charge your monitor. You're going to clear your patient, and you're going to push and hold. You push and hold the shock button so the computer in that monitor synchronizes that electrical discharge on that R wave. That's for fast and unstable. With fast and stable, we're going to try vagal maneuvers, adenosine, which they probably won't work with A-Fib, and we're going to go with calcium channel blockers or beta blockers. And then if get those started, you definitely need to seek a cardiologist consultation. All right, we're once again back to everybody's favorite slide. In summary, remember with the wandering atrial pacemaker, it wanders outside the SA node and back into the SA node, and outside the SA node and back into the SA node. It wanders back and forth, so that P wave changes with every heartbeat. Then there is MAT, multifocal atrial tachycardias. There are at least 3 different P waves. At least 3 different P waves. So that means there's 3 different ectopic foci in your atria causing this rhythm. Then we have PACs, that premature atrial contraction, which is just one little beat. I want to start the wave. And it does. Then we have PSVT, and you see it, paroxysmal. It comes and goes. You see it happen. And if you see PSVT and they are unstable, we can treat it at a lower joules setting, 50 joules, with our synchronized cardioversion. That's if they're fast and unstable in PSVT. Then PSVT grows up into big brother, which is SVT, Supraventricular Tachycardia. It's really fast. The P waves are hidden in the T's because it's so fast. And when that heart rate is so fast, the ventricles are not filling up. Then we have A-Flutter and A-Fib. A whole lot of shaking going on. So remember those treatment algorithms. If they are fast and unstable, synchronized cardioversion. If they're fast and they're stable and they're narrow, we're trying vagal maneuvers. Adenosine, 6 milligrams rapid IV push followed by 20 cc flush in 1 to 2 minutes. 12 milligrams of adenosine. Rapid IV push followed by 20 cc flush. And if that doesn't work, calcium channel blockers or beta blockers. You pick it. Hopefully enjoyed the presentation. Have a great day.